Good morning. My name is Rachel McLatchie and I'm an ST6 trainee from Edinburgh. I'd like to start by talking to you about Mr. A. He's a middle-aged man who presented to our ED a few years ago, complaining of sudden onset central chest pain, stabbing, worse on deep inspiration. His ECG, troponin and chest x-ray were normal, unremarkable set of observations, and the treating clinician thought it was probably just a bit of esophageal spasm. But his symptoms were quite severe, not settling. They admitted him to medicine just for a bit more observation, symptom control. The medics wondered if he might have a PE, so they checked a D-dimer, and it came back at 73,000. This was in the evening, so they requested a CTPA for the following morning, but anticoagulated him overnight. Unfortunately, overnight, he deteriorated, and the scan was expedited and showed an extensive type A aortic dissection. He was rushed to theatre. Is it just Mr. A, or is it just us in Edinburgh who gets this wrong? Well, no. Previous research has shown that across the UK, we have 1 in every 4 patients with an acute aortic syndrome is not diagnosed until 24 hours after their initial ED presentation, with a misdiagnosis rate of up to 38%. And time is of the essence because the mortality rate increases by 2% for every hour that we delay. However, it's not an easy area to research. Only around 1 in 1,000 of the atraumatic chest pains that we see in our EDs will have an acute aortic syndrome. It's a needle in a haystack. And to make matters worse, it can also present with other common symptoms like back pain, abdominal pain, and collapse. The potential pool of patients is enormous. And prospective recruitment's a challenge because in order to recruit a patient, the clinician probably has to suspect that acute aortic syndrome is a possibility in the first place. The Hawthorne effect worth considering. Clinicians' practice might be influenced by knowledge of a study underway. So in this instance, we decided to proceed with a case series cohort study retrospectively, and we acknowledged some of the limitations with retrospective research, but this is the only such case study to be published in this group of patients, to be done in this group of patients in the UK, and we do believe it goes some way to answering questions about this patient group and why they're missed. So the primary aim of our study was to better understand why acute aortic syndrome is missed in UK EDs, and secondary, to characterize the presenting features of these presentations. The setting was 3 UK EDs, the Royal Infirmary of Edinburgh, St John's Hospital in Livingston, and Wexham Park Hospital in Slough. We recruited every patient in whom there was a diagnosis of acute aortic syndrome over a 10-year period, and the dates are up on the screen there. Cases were identified from searching all relevant CT requests and reports during that time period, and also by trawling ED M&M records, complaints, and post-mortem reports. Data was collected about the age, the gender, the presenting features, D-dimer results, alternative diagnosis made, chest x-ray findings, CT findings, and time interval between ED presentation and diagnosis being made. And the reason for misdiagnosis was determined by 2 independent reviewers per case. So these show you our inclusion and exclusion criteria. And basically, just to summarize, the main inclusion criteria were that a diagnosis of acute aortic syndrome was made on CT scan within 7 days of discharge from the ED, whether that was home or to a downstream inpatient specialty, or death within 7 days from ED discharge with a subsequent post-mortem diagnosis of acute aortic syndrome. This shows the number of cases and their respective sources from the 3 sites. I've grouped together the Royal and St John's, which are in the same health trust, and Wexham Park, and those were 2 separate teams who pulled that data. In total, there were 43 cases identified. The most common of the acute aortic syndrome diagnosis was a type A aortic dissection, representing approximately 50%. And these were the presentation characteristics. So the most common presenting complaint was chest pain. That accounts for 63%, but only around a quarter of those chest pain patients described it radiating to their back, as the textbooks would have us expect them to. Around a third presented with back pain, a sixth with neurological symptoms, and presyncope or syncope was a factor in around a fifth. And clearly some patients had an overlap of multiple symptoms. Of particular significance, though, was the term sudden onset, which was quoted in the ED notes of 65% of these patients. So in 42 of our 43 cases, the problem was that the incorrect diagnosis was made in the ED. The most common of those was acute coronary syndrome. Second runner-up joint were PE and non-specific chest pain, and some others seen on the screen there. One case, the ED clinician did actually suspect acute aortic syndrome and requested a CT appropriately, and unfortunately the CT was misreported. That's one of the reasons listed here. So this slide kind of importantly sums up why the ED clinician missed the diagnosis. And just in bold there, I'll draw your attention to the fact that in 72% of cases, from reading the notes, there was no evidence that it had even been considered at any point in the differential diagnosis. Bear in mind that there's multiple contributing factors to some of these as well. In 28% of cases, you could see that the clinician had considered it in their notes, but they were often reassured inappropriately by things such as a normal chest x-ray or atypical symptoms presentation, or the symptoms having resolved during the consultation. So the median time from ED arrival to diagnosis of acute aortic syndrome or death of the patient was 15 hours. And around a third of the patients in this cohort sadly died during the same hospital attendance. So I'll touch on some of the key themes and take-home messages in a moment, but first I'd like to acknowledge some of the limitations of our study. It was a relatively small sample size, and just being 3 sites and 42 cases. That said, we do believe our search strategy was thorough, and that this patient cohort is a generalizable result to our UK ED population as a whole. As mentioned before, we are aware that retrospective data collection is never going to be as robust as prospective, given that this study was dependent on the quality of the documentation made in the ED, and missing data was irretrievable. That said, it was only in 2 of the 43 cases that we were unable to draw a conclusion about why the diagnosis was missed from the notes. And we attempted to mitigate for some potential bias by having 2 reviewers per case to determine the reason. Also, in this case, in this study, we were unable to draw any conclusions about D-dimer. It's just not the right study to do that. But of note, 11 of the 43 patients had D-dimer checked, and 10 of those were positive. So it does whet the appetite for further research in that area. So in a nutshell, clinicians' awareness of this rare yet lethal condition does need to improve. This includes understanding of how it can defy the textbooks and present atypically with reassuring clinical signs or chest x-ray findings. And prospective research in this field is challenging, but it is necessary to answer further questions, such as how clinical risk stratification scores and biomarkers such as D-dimer could be helpful. So what's next? Well, with the ambition of answering some of these important questions around the use of risk scores and D-dimer, I'm proud to let you know about DAShED, which is a study of which I'm the chief investigator in association with Professor Matt Reed. This study is the first phase of 3, and it aims to describe the characteristics of ED attendances of patients with possible acute aortic syndrome. We want to determine the service implications of using different diagnostic strategies, and we hope that this will inform future research. We're delighted to have received funding from the Royal College to pursue this study, and we have started recruitment from 2 of our 15 sites this week. I'd like to acknowledge the following individuals for their help and support, and these are some references I used. I'd be delighted to welcome any questions.
Thank you. I'm sure I'm not the only person in the room who's slightly terrified by what you've just presented. Appreciating that further research is going to happen, what should we be doing when we get back to our departments later this week to ensure that we don't make the same mistakes as you've described?
Sure. I think as the data revealed there, one of the most important factors is that we just don't consider it in the differential diagnosis. So that's around clinician awareness, and I think some charities have gone a good way to putting up posters in our EDs to raise awareness, but we can just keep on emphasising that in our education sessions. And also, it's not just about knowing it exists, it's about when to suspect it. So we all know the classic textbook presentation of the tearing chest pain going through to the back and the differential blood pressures in each arms and whatnot. But as we've seen, it presents in a really diverse manner. And I think education around the diverse presentations would be of use for clinicians of all stages. And just emphasising that we shouldn't be reassured by normal clinical exam or chest x-ray or ECG or whatever if the history is suggestive that this could be a possibility.
Trust no one, believe nothing. Ellen.
Well, that's true of many diseases. Yeah, very popular question is, should we be requesting triple scans, CTCA, CTA, and CTPA, as part of a routine chest pain workup when aortic dissection is potentially or not even thought of, but if it's a routine, should we just do that?
I can just hear the radiologist screaming.
I'm going to say no. Clearly, there is an overlap in the way that lots of patients can present when differentials do include things such as PE, acute coronary syndrome, aortic dissection. I think a lot of it has to go in clinical assessment, clinical decision making, but we should, as recent kind of ARCM policy has indicated, we should have a low threshold for suspecting if we suspect acute aortic syndrome, scanning these patients. However, the clinical risk stratification scores, such as ADDRS and use of D-dimer, I think could help us kind of direct which patients need the CT urgently, just to whittle down that group, because at the moment we are scanning. Well, in our hospital, we're about 5% of the patients we scan turn out to have a positive diagnosis for acute aortic syndrome. So there's scope to increase efficiency in that, but we are still missing it, So I think this further work on DAShED to look at roles of clinical decision-making tools and D-dimer could help us to specify which patients need a CT aorta.
Great. And kind of following on that, someone asked, what do you think about using the aortic dissection score?
So I assume that's referring to the ADDRS score, which is the most prominent of the scores in existence. It does look promising. It's not yet been validated in a UK population. We seek to do that, and that is part of the plan with DAShED. So the initial phase is going to be observational and using the data that we would need to input to these scores, extracting that for all the patients that present with potential symptoms of acute aortic syndrome, and working out which of these scores seem to be the best. In phase 2, we would then try to kind of implement use of these scores and validate them in our UK ED population. And in phase 3, we'd look at the clinical implications of that. So I do think that there's a real signal that it could be helpful, but more work is needed to be done here in the UK on that.
Can I keep going? Do we have time?
One last question.
One more. So there are just so many great questions here, but I'm going to ask this one. Did you see what grade of ED doctor the physicians were who missed these diagnoses?
Yeah, that was one of the data points that we did collect. However, most of them, although they were seen by all grades from FY2, nurse practitioners, registrars, consultants directly, because usually it's a chest pain presentation, the vast majority of them were discussed with an ST4 or above registrar or consultant. So it's hard to state whether it's because they were seen by junior doctors, but actually, they all had senior input in the way that these patients should. So I don't think we can draw kind of too many conclusions from that. They were all discussed with the senior.
Great.
One final question. How do we get involved with DAShED?
Say that again, sorry.
How do sites get involved with the study?
So we've already started actually our first phase, and we have 15 sites signed up, which is great. In terms of kind of taking things forward over further phases, if anyone is keen to get involved, then you can email us. We're the Emerge team based in Edinburgh, and you'll find us on Twitter and whatnot, so do just get in touch and we can think about how your site could get involved.
Thank you very much.
Thank you.